As far as emergencies go, I was interested in emergencies even when I was a resident. And if you look at the date on this article, it's from 1977. I did my residency at Nassau County Medical Center, which is in New York. When I got out of dental school, I was in the Air Force for a couple of years, and then I went into private practice for a couple of years, and then I went into my residency, which is why part of my bias about accepting students into our graduate program is to have people practicing for a couple of years. It makes a big difference when we see students who come in who have had some experience dealing with patients, as opposed to people coming in directly out of school where they're used to a faculty member looking at everything they're doing and taking their time doing it. So that's really part of our bias. Plus, part of my bias is I want the student to really know that's what they want to do for the rest of their lives. And you really don't know it until you've tried it a little bit. When I went to college, we went right on to dental school. Nowadays, at least in the United States, more people are taking time off to sort of find themselves. I have 4 kids, and all of my kids, when they finish college, I told them to go out and get a job for a year or 2 and see what life is like and see what you really want to do. And then you'll be more motivated to go back and do something else. And they've all done that. I have 2 that are attorneys. One is a corporate attorney. I hate to say that I have children that are attorneys, but they don't sue dentists. They have a corporate attorney and a patent attorney who is a PhD in microbiology. And I have my youngest daughter is a neuropsychologist, and my youngest son got his MBA, and he's a financial advisor or something like that. When it comes to finance, this school, you know a lot about finance. I don't know anything about finance. But so for all of you, when you get out of dental school, I would recommend go out and work a little while before you decide whether you want to go into a specialty or not. Unless you want to go into orthodontics. Because orthodontics isn't really dentistry. Do we have any orthodontists here? Yeah? I kid the orthodontic department. They're great, but there are different skills, and you're going to learn different skills in orthodontics that going out and practicing may not help you with. You know, you'll forget about how to give anesthesia and things like that. So anyway, 1977 is when we first did that paper, and then 10 years later, I was teaching at LSU, which is Louisiana State University, and one of my residents decided to redo this project with me about finding out what endodontists were doing for emergencies, and that was Scott Gatewood, and he went on to become the chairman of the endodontic department at the University of Mississippi, where he still is today. And then we redid the survey a couple more times, once with Joe Barrows, who practices in Miami. He was one of my residents at Nova. And then again, 10 years after that, Michelle Lee up in New Jersey did it, but not quite the same question, so we don't have really a complete survey, but we're going to be doing it again when it comes to 2019. The goals of this survey. This survey was pretty extensive. We wanted to see throughout all these decades what endodontists were doing. Were they changing things? And we had to get a baseline, which is why we started in back in '79. Actually, we started in '77, and it took 2 years to get through everything. That was the days before computers. And it was a massive job to get all the statistics together. But we looked at things like number of appointments, the length of the instrumentation, medicaments we were using in canals, antibiotics, analgesics, things like that. This is the survey that we sent out to everybody. It's massive, and a lot of people just didn't fill it out because there were a whole bunch of pages. We wanted them to fill this out for anteriors, for posteriors, and for different situations. This is the classification we use. What I decided is we're going to get a sort of basic classification. So like I told you before, we divided it into the vital pulps and the non-vital pulps. In the vital pulps, you had two situations. Either you had apical periodontitis or you didn't. So that's sort of easy. But getting to the non-vital pulps, we had a problem because we started off with either you had swelling or no swelling, but then we wanted to know, well, does it make a difference if it's fluctuant, where you have a nice round ball of pus, or whether it was sort of diffuse, and whether you were getting drainage through the canal or not. So we try to get all this information. Some people just sort of wrote it off and wrote X's through a whole bunch of things. But we ended up getting it together, and I'm going to show you some of what we've seen over the years, and then we'll correlate what you should be doing now to treat emergencies. Okay, so let's start with vital pulp. And vital pulp without apical periodontitis. Okay, if you remember, vital inflamed pulp will respond to cold, will respond to heat, and will respond to electric pulp testing. That is your typical hot tooth. You use that term here, a hot tooth? Okay. So, before we go into that, let's talk about anesthetizing a hot tooth. Because those of you in the clinic, I'm sure, have had patients where a patient comes in and they have a toothache and you cannot get them numb. Okay? Has that happened to many of you? No? You're not working in the clinic yet? Or everybody's asleep? Yeah? Long break. That's why I had coffee. Anyway, there are different ways we could anesthetize for a hot tooth. And we're going to talk about some of these. Okay, for maxillary teeth, especially the anterior teeth and the bicuspids, it's very easy to anesthetize the patient. You almost never have a problem with that because if you look at the end of the roots, they're right up here. There's hardly any bone over those teeth. You do an infiltration and the pain goes away and the patient loves you. Okay? Maxillary molars are a little bit more difficult because you have so much bone in there. And if you have a patient with a hot tooth, what I would recommend is a posterior superior alveolar block. Okay? Now what you do with that is use a short needle, go up just distal to the second molar. Okay? That's important. You want to go vertically distal to the second molar, hugging the bone. Okay? Because remember you have the malar process there. And if you hug the bone, you won't get into the pterygoid plexus at all. So you want to go up there, aspirate. If there's any bleeding, you pull out and you try it again. But if you inject it up there, you're going to block both the third molar and the second molar and two of the roots of the first molar, the distobuccal root and the palatal root. And if you're working on the first molar, the mesiobuccal root is right near the external part of the bone. You could easily give some infiltration over that. So it's easy to block maxillary teeth, even when they're hot and inflamed, if you do it this way. The mandible is where you have the problems. People always have problems with mandibular anesthesia, even with regular teeth. What you're aiming for with a mandibular block, a normal one, is to get the solution right here. But there's a lot that you're going through before you get there. And it's sort of a blind technique. So if you have somebody in and they either tell you that they're difficult to get numb or they're having a lot of pain, I would go to something called the Gao-Gates injection. Now, I know Dr. Malamed was here. Did he talk about the Gao-Gates? And I don't know if all of them heard about it. That's one of his favorite injections. So I'll just go over it briefly to remind you some of it. This is what we're aiming for when you give a mandibular block, but it's very elusive. This is where we're aiming when we give a Gao-Gates. We're trying to get the solution around the mandibular nerve up further here, okay? So remember this picture. The mandibular nerve is actually coming right along here and then sinks deep down into the bone. And that's what you want to get. So what you're going to be doing is turning the patient so they're lying back. You want to have them completely supine. And the reason is when they're lying back, the solution is then going to work its way down here. And you also want to have them keep their mouth open while they're doing this. So you have the patient lying back. You're going to find the tragus. Okay, the tragus of the ear is that little fleshy part right there. And that's what you're going to be aiming for. You're going to come from the second bicuspid on the other side and aim for that. And that way, what'll happen is you'll hit the bone at the neck of the condyle, high up where that arrow was. The tricky part is you have to keep the mouth open for 60 seconds. Now, when Dr. Gao-Gates first devised this, he said you had to keep the mouth open for 120 seconds. A lot of people couldn't do it. You don't realize how long that is when you're keeping your mouth open. So just as a little hint when you're doing it, have the patient lying back, keep either your finger or your assistant's finger inside the mouth so they don't accidentally bite down, and talk to them. Talk to them the whole time. Make some jokes. Tell them that you know it's tough keeping open for 60 seconds, but the reason we're keeping you open is your muscles are forming a triangle, and the solution is going to stay there, and if you close your mouth, it's going to close the triangle, and it won't work, and by lying back, you just keep on like that. And then all of a sudden, 60 seconds are up. But they have to keep their mouth open for a while. And it works. According to Malamed's study, 95 to 98% of the time it works, which is different than a regular mandibular block. Okay, this is the neck of the condyle. This is where we're aiming for with the Gao-Gates. This is where you're aiming for with a regular mandibular block, and you have this spine of bone right in front of that, sort of blocking your way into there. Now, even with that, it doesn't always work, especially when you have a hot tooth. Years ago, a lot of people used to do periodontal ligament injections. I hated those. Those were painful. I don't know if you've ever had one done, but they are painful. They don't do those as much anymore because we now have intraosseous injections. And I would urge you to learn how to give an intraosseous injection. It's very simple to do once you get used to it. There are two different types. There's the Stabident, which is what's shown here, and there's something called an X-tip, which I'll show you a picture of later. When you're doing that, first thing is you have to just anesthetize the gingiva because they're going to feel that. But if you anesthetize the gingiva, it'll also infiltrate into the bone, and the bone will be anesthetized, and the patient's not going to feel it. Then what you do is you take the perforator, and this is the perforated. It goes into a slow speed drill, and it's the same size as the ultra short needle that you're going to use that comes with the kit. So you get a perforator and the needle that goes on the syringe. Okay, so now what you do is you're going to go into the cortical plate, and if you're using the Stabident, you have to stay in the attached gingiva, because otherwise you won't find that hole afterwards. But it's going to make a hole in the attached gingiva, so you go in, if you can, distal to the tooth you want to anesthetize. If you can't, even mesial will work, because it spreads out. So you go in at right angles and tilt it 45 degrees so it's going down towards the apex of the tooth. This is an X-tip. It's called an X-tip because when they first came out with it, they had this thing sort of shaped like an X, but now it's cheaper just to make a round one. This is different than the Stabident in that this stays in the patient's mouth, at least for a little while. You put that in and you see this little hole here, and I don't know if you could realize that it's going in at a 45-degree angle, and then you have a hole there to put your needle in, your ultra short needle, and you just put it in there and inject slowly. And if you're using epinephrine, make sure you tell the patient that they're going to have some fast heart rate, whatever simple way you could tell it for them. You don't tell them tachycardia, because half of them don't know what tachycardia means, but their heart will be racing, but it'll go away in a minute or so, and that just means it's working and there's no problem. If somebody really has a heart problem, you could also do it without any epinephrine. Now, I put this in as far as an intrapulpal anesthetic. I haven't used this at all in the past maybe 5 years. Since we're doing the intraosseous, this almost never comes up. But if you have to do it, you should know how to do it. It's really a last resort. It's a very painful injection. So be prepared if you're going to be doing it. Use a 30-gauge needle, and you're going to go either into the canal, or if you were excavating the tooth and got a little exposure and the patient's feeling it, don't wait for it to become a big exposure. You want it small. So you want to put a little drop of anesthetic down in the canal with pressure. And the reason with pressure, it's the pressure that anesthetizes in there, not the anesthetic. They did a study at Ohio State University with both saline and anesthetic and found out worked just the same. You could use saline. It's just more convenient to use an anesthetic syringe. An anesthetic because it's sterile. But it doesn't make any difference what kind of solution you really use. You have to get pressure in there. Okay, so hopefully we're all set with our anesthetic. I don't know if anybody has any questions about that. I went through it sort of fast, but I figured Dr. Malamed was here already, so he probably went through all of that with some of you, whoever was here then. This is the video that I couldn't get to work. I was transferring this over from my other computer. So I'll explain to you what this is. There are different ways that we remove pulp tissue. Okay? One of them is a pulpotomy. And what a pulpotomy is you're just taking out the coronal part of the pulp, especially in a multi-rooted tooth. You could do it in a single rooted tooth too, and sometimes we do if time is of the essence. And what we want to do is take it off to this level. So you go in, you make your access, and you remove it usually with a slow speed round burr that's sharp down to about that level. Another way we could remove pulp tissue on emergency is by doing a pulpectomy. And when I got to the University of Texas, they used to love to do pulpectomies. I was always told we called it urgent care clinic, but the emergency clinic, they would be doing pulpectomies. Well, a lot of these pulpectomy patients we saw coming back with pain, because a pulpectomy really means going in, taking out the pulp. But what happens is, unless you're going to completely clean out the root canal, there's tissue still left in there. And nerve tissue is the last tissue to degenerate, so there's still nerve endings in there, and some people will have a lot of pain afterwards. So I wrote a memo, and we discussed it with the faculty there, that they're not doing pulp extirpation anymore. It's either pulpotomy or they do the complete treatment. And then, of course, you could do complete instrumentation. And we'll go into that later. Again, we never discussed what you're teaching here, but what I say might be heresy, it may not. I believe in one visit treatment. And there's only one reason not to do it in one visit, and that's when you don't have enough time. When we first did the survey back in 1977, nobody did anything in one visit. Not at all. Everybody was doing it usually in multiple visits. About 15% were doing pulpotomies, 30% would do the pulp extirpation. Nobody was doing it complete treatment. By 99, almost 80% were doing one visit, especially with vital teeth. Almost 80%. Now, these are all endodontists, so it's easier for them to do it in one visit than somebody just starting out who might take 5 visits, because you have to get these different things checked off, and you might have to take 5 or 6 x-rays before you could get one that's okay for the instructor. But think of your goal. Okay, degree of tissue removal. You could see here, pulpotomies were low, pulpectomies a little higher, complete instrumentation. This is around the turn of the century, and 99 was up there very high. And it wasn't that way originally. But the only time they were doing pulpotomies really were the vital teeth, which is that first line there. So let's talk about one visit treatment. This is 1988 versus 99. Remember, in 79, nobody was doing one visit treatment at all. Now, by 99, we have more and more doing it, mostly with the vital teeth, not as many with the non-vital pulps. And I keep saying vital teeth and non-vital teeth. Forgive me, that's wrong terminology. Okay, now, why has it changed? One reason it's changed is we have the rotary nickel titanium instruments that we didn't have back in the 70s. We didn't have any rotary instruments back then. We now have apex locators that we're having all of our students using, including the predoctoral students. And the digital radiography. A lot of dentists have digital radiography, so if you want to take a radiograph, it's only going to take you 30 seconds to see it right up in your screen, instead of having to go over to the developer and do it wet and look at it and put it back in and stain your clothes and all of that. With apical periodontitis, remember, that's inflammation of the periodontal ligament at the apex. Positive response to percussion. The treatment was the same. Okay, so right now we've simplified this. It's the same, a vital pulp. It's the same treating that if you have apical periodontitis as if you don't. So we've simplified a few things. Okay, level of instrumentation. This was confusing from 77 to 99 with vital teeth. They were basically the same as far as short and long. It may have changed a little bit here, but then we started thinking, what apex are we talking about? Because more and more people were using the apex locator. And the apex locator, apex is different from the radiographic apex. So if you're using the apex locator, you're always short. But you're saying that's to the apex. So saying to the apex and short of the apex may be the same thing, depending on who you're talking to and what they're talking about. One thing we found out is in the last one that Michelle Lee did at New Jersey is that 60% of the endodontists are now using electronic apex locators to do their final determination, not a radiograph. And that happens to be a problem with the Board of Endodontics right now because they want to see a final instrumentation radiograph, a master apical file. And I have taught my students that they don't need that. If they know how to use the apex locator, they could take their preoperative films and their postoperative films and not radiate the patient in between. So we're in a battle right now with the Board of Endodontics. We're trying to take less and less radiographs and use them when they're really necessary. So
you're using a locator, you're going to be always short?
You're going to be always short of the radiographic apex. Okay? Because the radiographic apex is usually long. The apical constriction is anywhere from 1/4 of a millimeter up to as much as 5 millimeters short of the radiographic apex.
The question would be with the viral tooth that you do in endodontic and you leave short the canal or your obturation,
Yeah.
it's going to be left some vital pulp there or some organic pulp there.
If you're doing it correctly, and did you hear what Dr. Alfaro is asking? He said if you're using the apex locator and it's short of the radiographic apex, you're leaving some pulp tissue in there, right? Well, you're not. If you're using the electronic apex locator correctly, you're going to the true apex, to the true apical constriction, which means what's past there is periodontal ligament. It's not pulp anymore. And all you're doing then is irritating the periodontal ligament, which is why I don't really believe in patency files, because that's irritating the periodontal ligament. Even though Steve Buchanan is coming to Houston in a couple of weeks, we're good friends, and we used to stay up till 3 in the morning arguing some of the facts about patency files and how you do your crown down. Endodontists are just weird. We're using, I know everybody asks me, what brand are you using? We're using the Merida apex locators, but in a study that we did in Nova, we found out that this Just 2, which is from Japan, actually was better than the others. They were all accurate to within 95%, but this is the only one that didn't give us any long readings. When it was inaccurate, it was always a little bit short, which is preferable. Okay, so let's summarize vital teeth, or teeth with a vital pulp. Number 1, complete it in one visit if you have time, right? Almost 80% are completing it in one visit. And I'll bet you it's going to go up. If time is critical, do a pulpotomy. Don't do a pulpectomy. Okay? Just do a pulpotomy, which means take out the coronal portion of the pulp. You don't even have to put in any medication. Put in a piece of cotton and cover it up. Hasselgren did a study on that and found it doesn't make any difference. If you put in eugenol, if you put in formicresol, doesn't make any difference. If you put in calcium hydroxide, I'll show you, no, that's tomorrow. I'll show you the difference it makes. What it does is it causes calcification. And sometimes it can be tough getting through that calcification. And there are some people that are now saying do the pulpotomy with MTA. That's the new magic wonder drug in endodontics. The problem with MTA is, I don't know how many of you know what MTA is. It's Portland cement. It's concrete. And if you put concrete into a person's tooth and fill up the chamber with it, and then you want to go back to finish up the root canal treatment, it's tough drilling through concrete. And you may end up perforating. So you get beautiful results, and the patient is comfortable, but I don't want to go back through concrete. So don't use MTA. Instruments short of the radiographic apex, if you're doing a vital tooth, and remember that's short of the radiographic apex, not the apex locator, apex. And by the way, if you get an apex locator, some of them still have inaccurate directions, because even the apex locator manufacturers don't understand what it's measuring. It's measuring the apical constriction, the narrowest part of the canal before it starts to widen out. You could adjust the occlusion if they're having pain when they bite, and you could suggest over-the-counter analgesics. We really are getting away from prescribing a lot of medication, getting away from prescribing a lot of narcotics especially. I don't know if there's much of a problem here, but in the state there's a big problem with narcotics. And the people that will have the biggest problem with patients wanting narcotics is the young dentists first opening in practice, because they don't really know how to say no. And a lot of the people coming in that are addicts and just want some medication will tend to come in just before 5 o'clock, and they'll say, oh, I don't want to keep you, I don't want to keep you from your family. You could just write me a prescription, I'll come back tomorrow, and they'll never show up. And sometimes they'll tell you exactly what they want. It won't be anything simple. If you give them like an NSAID, they'll say, oh, no, that doesn't work on me, or I'm allergic to it, all sorts of things. Okay, now, let's talk about the non-vital pulp. Okay, you might think this might be a little different. So, we have non-vital pulp with no swelling. Something like this. I don't know if you can see the sort of small lesions in here. There's a pulp exposure here. When the tooth was tested, there was no response to the electric pulp testing. There was no swelling at all. The patient didn't feel anything with hot or cold. Open into the chamber, it's just empty. Okay? What is the emergency treatment? Basically the same thing as a vital pulp. So that makes it easy. Right away, we don't have different types of treatment. You don't have any pus coming up through the canal. It's just a necrotic pulp. Treat it in one visit if you can. There was some discrepancy whether you should be short or whether you should be to the radiographic apex, but most people said go ahead and complete your instrumentation. About half of the people said finish it in one visit, and about half of the people said use calcium hydroxide. Okay? Now, I know a lot of people like calcium hydroxide. For a long time, that was our wonder drug, and everybody was using it for everything. I hardly use it anymore, and this is my own personal opinion. Some people believe you have to put calcium hydroxide into a tooth between visits to disinfect the tooth. To me, the reason that's working is because you're finishing the treatment in one visit. Except instead of obturating with something like gutta percha, you're obturating with calcium hydroxide. Then what you're doing is you're going back probably a week or two later and retreating the tooth. You're going back in, taking out the calcium hydroxide, cleaning out the canals. You're probably not getting all the calcium hydroxide off the walls unless you're widening the canal too much. And then you're going to obturate with gutta percha. Well, you probably left some calcium hydroxide along the walls, which could dissolve out if there's any fluid in there, and you may not have a good seal. Plus, you cheated yourself. You didn't charge for a retreatment. You only charged for the first treatment. Why not do the first treatment and that's it? And we found with the studies, there have been a lot of studies from here and in Europe, success failure studies, pain studies. There's really no difference between one visit and multiple visits. So there's really no reason to do multiple visits unless you don't have enough time, okay? But we're still going to find a lot of people that want to do calcium hydroxide. While I'm talking about calcium hydroxide, some people might kill me. Some people believe, well, you have to get all the bacteria out of there. Well, one of the things we found is that there's a bacteria called E. faecalis. E. faecalis is what's been shown to be in more treatment failures than any other bacteria. Okay, it's not the only bacteria, but that's been there more often than not. And when it's successful, we can't culture E. faecalis up there. Well, guess what? Calcium hydroxide does not work against E. faecalis. So why are you putting it in there if the bugs that cause the failures are not being taken care of by the calcium hydroxide? Okay? E. faecalis is eliminated by using sodium hypochlorite. Okay, enough of the soapbox. No antibiotics. This was surprising because when we started this back in '77, we thought if you had an infection, you had to give antibiotics. As a matter of fact, there were dentists writing that you should give antibiotics starting 2 days before you do the endodontic treatment and then 2 days afterwards, and not just for heart problems, but for every non-vital tooth because you wanted to kill the bacteria. Okay, swellings. This kid came in with his mouth all swollen like this. Guess what? With the swelling like that, this was 2 days later, 48 hours later. Okay, one visit. And what we're doing, and a lot of oral surgeons may disagree, but what I'm teaching my residents is when you have a swelling like this, first thing you're going to do is anesthetize the patient, do an IND. We'll get into INDs a little bit more later. That relieves the pressure. Then you put in, well, we'll show it later. You put in a drain, then you put your rubber dam on, and you do your endodontic treatment. And guess what? It's a lot easier to get the tooth dry and get the drainage stopped because you've already drained it out through your IND. So you could finish it in the one visit. And this came back 48 hours later. Nice and smiling. Okay, just before lunch, I wanted you to see a nice hussy tooth. And of course, as it's draining out some more, it's going to turn into blood. We're all used to that, but by doing the IND first, we can get that draining beforehand so we don't have as much through the tooth. Now, we talked about whether we should instrument past the apex or not. And in '77, a lot of people were instrumenting past the apex when there was a swelling. But that's becoming less and less. And you can see even with the numbers, we're way below 50%. So more people are now instrumenting to the apex, which is probably to the electronic apex. So I think I mentioned this to you already. We asked this in the 99, what do you rely on most? 40% radiographs, 21% apex locators, 34% was a combination. and 2% was others. And in 2009, it's 60% are relying just on the apex locators. Okay? So this is now up to 60%, plus the others are using more of a combination. Some are still using radiographs. And that's what we're heading to. We're heading to just apex locators and not taking as many radiographs. The length of instrumentation, we'll go through that quickly. If you look here, blue is short of the apex. This purple is to the apex, and the cream colored is past the apex. And there are still quite a few endodontists that are instrumenting past the apex when you have non-vital pulps, because they want to make sure they're getting drainage. Okay? But if you get the drainage externally, you don't have to worry about that. So we're going to see if we change things for the next survey, and especially when some of our articles come out that we're preparing now. How about leaving the tooth open? At one time, the emergency treatment for this was to open the tooth, leave it open, patient went on their way. This is what could happen when you leave it open. A foreign object, here's a foreign object. This patient came into an emergency room, they opened the tooth, and they told the patient to go home and come back next week. We got this out, and it turned out to be a little plastic bead that kids use to make necklaces of. She's probably taking one off, and it went up in there. Luckily, we were able to get that out, but sometimes some of these things could be wedged up there pretty tight. We had one at the school where she was told to put a needle in to clean the food out. And I should have put that radiograph in here too, but there's actually the broken off needle that you could see in there. They do strange things. We shouldn't be leaving teeth open, okay? We could open with an IND, there's no reason to leave a tooth open. And of course, you could see here, I don't have this is back in '77. A lot of people were leaving teeth open, especially when there was drainage through the canal. And then by '99, it's less and less. So we're getting away from that. We realize that when you leave a tooth open, it's just getting infected more and more. And we want to stop that infection. Back when we did the first article, one of the companies who makes little plastic drains, I don't know if you could see it back there, but they quoted our article as saying that teeth are left open. And actually in there was one person who said, it was Irv Nadoff. I don't know if any of you remember Irv Nadoff. He was the editor of the journal, and he said he never ever leaves a tooth open except on Friday. And that's the quote they have here. They changed a little bit. When it's fluctuant, you have more people doing an IND than when it's diffuse. I would recommend doing it more often than we do it. And I think the reason we don't do it is patient comes in all upset. Sometimes the dentist, the endodontist, doesn't like to cut. They don't like to get the patient numb and cut. They think if they put a drain in, it's going to be a big procedure. But I'll show you how we do it. This is what we use. Now, in the past, a lot of people said you have to cut a piece of rubber dam into a T shape and put that in. First of all, a rubber dam is not sterile, but you could wipe it with any sort of sterilizing agent, make it somewhat sterile, and they cut it into a T shape and sew it in with a suture. You know how uncomfortable that is to have this thing sewn into your mouth, and then the patient has to come back to you for you to take the sutures out. It's so much simpler to take a piece of iodoform gauze. The iodoform is on there so that it it sort of retards the bacteria. You can get this gauze without iodoform if you have a patient that's allergic to iodine or to shellfish. But all you have to do is cut a little piece of that off and put it into the opening you made. I don't know if you could see that back there, but here's the gauze just sticking out. That will allow it to drain. You do this, and then you put your rubber dam around the tooth and do your endodontic treatment. Not that much is going to come out that you have to worry about the patient swallowing it all, and they'll swallow it and not know what they're swallowing. It's their own bodily fluids. But this is an easy way to do it, and then I always have the patient come back the next day for a 5-minute appointment. Because they come in, I make sure all their swelling is down. That kid came in 2 days afterwards because it was a weekend. But all you have to do is take a forceps and take it out quickly. You don't have to anesthetize them. It's like taking a bandage off. You know, you just take it off quick. And most patients don't worry about that. The reason I like to see them is to make sure that the gauze drain didn't go in, and to make sure that I take it out. Or sometimes they'll tell me it came out, and they just threw it away, and that's fine. Because you only need it for 24 hours. Okay, trephination is something that very few endodontists do, and I wouldn't recommend any of you doing it, but you should know about it. Sometimes when you just can't get a tooth comfortable, there's no drainage, there's a thick cortical plate of bone, so the pressure can't escape. The best way to do that is to make your own hole. And here's a case where we had an emergency. It happened to be a retreatment. So I knew I wasn't going to get all of that out and didn't have the time to do it. So what do? We go in there with a handpiece, and I don't know if you could see, I could see it beautifully on my screen here. Okay, here's the bone cutting drill. I like to use a Lindemann drill, or there's another one that I'll show the residents that cuts through the bone very quickly and easily. We make just a little incision, tiny incision. This is bone, and you have to know exactly where you're going, especially up here. You don't want to be into the sinus. If it's lower mandible, you don't want to be into the mandibular canal. And here we are, some pus is coming out, but that's the iodoform gauze. Okay, so we just made our own opening into the bone and not got the patient feeling well right away and didn't have any pain after that. Then we could go in and retreat that tooth whenever we have time. Okay, I promised I'd talk a little bit about calcium hydroxide. I already did to some extent. Calcium hydroxide isn't bad. It's just that I don't like to use it as a medicament for inside the root canal. It is great if you have a deep carious lesion. It'll get tertiary dentin to build up fine. It's very high pH, around 12, which is good for getting rid of some of the bacteria that have to live in a negative pH. So it has its uses. Inside the root canal isn't necessarily one of them. But that being said, over the years, more and more endodontists were using calcium hydroxide. And there are still battles going on. We're talking about whether we should be using calcium hydroxide or not. My recommendation is don't. Now, there were different types of phenolic compounds. The older people know about CMCP. You were really an endodontist or an endodontic student if you know how to say camphorated monopyrachlorophenols. fast. Now nobody knows what it is. Crescidin, remember Crescidin? That's what they put on telephone poles to stop it from rotting. That's what they were putting in teeth. You can see back in 77, 30% of the endodontists were using these different compounds. Now, happily to say, zero. And that includes former Cresol to some extent. We still have a couple of holdouts with former Cresol. We had a joint meeting, I think it was 3 years ago, with the pediatric dentists talking about things like this and whether we should do former Cresol pulpotomies or not. And the pediatric dentists love former Cresol pulpotomies. We think it's horrible. We both have research to support our feelings. So from my end of it, former Cresol, number one, is carcinogenic. Number two, can cause bone deterioration. And very quickly, if you put too much of it in, there have been case reports where people have not really dried it out real well, and you got a lot of osteonecrosis. So endodontists don't like it. A lot of pediatric dentists say there's nothing wrong with it, it kills the bacteria, go ahead and do it. I would rather see just a zinc oxide eugenol filling in there, not an IRM, but an old-fashioned zinc oxide eugenol filling, because if that goes into the deciduous tooth, it's going to resorb at the same rate as the tooth. And that's why we don't use any of these other fancier compounds. Now, some people are saying that eugenol is a problem also. And there was an article as far back as the 70s by Kozam, we were talking about it last night, that said they found eugenol all the way up through the mandibular nerve just from putting it in a pulpotomy. So I don't know where we're going to go with eugenol either, but for right now, if you do a zinc oxide eugenol filling and dry it out, apparently there's not that much free eugenol that you have to worry about. It's the free eugenol that you really have to worry about. Okay, and more people are using no medication. Okay, look at this. We're up to, it's what, about 25% average, no medication. And that's what I believe in. There's no reason to put medication in there, even if you can't finish it one visit. Just put a piece of cotton in and make sure you have a good seal. It's the seal that's important, not what you're putting in there. Some people are saying you have to put the medication in, the medicament in case the seal leaks. Well, do it right so it doesn't leak. Okay. Occlusal adjustments, yeah. A lot of people do occlusal adjustments, especially when there's apical periodontitis, but I would recommend it on almost all cases. Why take a chance that the patient is going to bite down hard and start aggravating it, especially if you're going to be doing a crown? Do the occlusal adjustment. You don't have to really grind it down a lot just so that they're not hitting hard. Antibiotics, you can see with the non-vital pulp, there are more and more people using the antibiotics. These are susceptibilities from Craig Baumgartner. Craig Baumgartner retired. He's now living the hard life in Honolulu, Hawaii, where his wife is originally from. He comes back to the mainland every once in a while. He was probably one of our foremost bacteriologists in endodontics, and now Christine Sedgley took over, and she's in charge of the program, but she's also a bacteriologist. And then probably the foremost microbiologist in endodontics right now is Jose Sequeira from Brazil. He's doing phenomenal work, and I have two of his residents on my faculty now. So Actually, we got him to speak at the AAE 2 years ago for the first time. So, yeah, we talked a lot. Anyway, Baumgartner looked at the susceptibility of endodontic bacteria to different antibiotics. And here's what he came up with. The strongest antibiotic to use for an endodontic infection is a combination of amoxicillin and metronidazole, 99%. The only problem with that is that metronidazole is disliked by a lot of patients because it gives them a metallic taste that's very annoying. Plus, legally in the United States, you're supposed to tell your patients that it's been shown to cause cancer in mice. Okay, now you're not giving it to mice and you're not giving it the same dosage, but that's in the PDR thing. So what we've been using mostly is clindamycin, 300 milligrams, 4 times a day, 96% susceptibility, especially the gram-negative anaerobes. And right behind that is amoxicillin at 91%. So these are our 2 basic antibiotics, that when we have to use antibiotics, that's what we're using. Okay, either amoxicillin or clindamycin. Now there's been a lot of research lately and a lot of editorials in journals like O and Journal of Endodontics that we should be prescribing antibiotics for shorter periods of time. There was one study that asked patients how long they really took antibiotics, even though they were prescribed antibiotics for 10 days. And most of them took it for 3 days, they felt better and they stopped taking it. People don't take it. And if they don't take it and they get better, why are we giving it to them? You know, are we increasing the possibility that they're going to have reactions to it, that they're going to become allergic to it? Are we increasing resistance to some of these antibiotics by giving it to them longer? At one time, we were told you give it to them for a long period of time and they're less likely to become resistant to it. Now the thinking is they're more likely. So we're giving it basically for 3 days now, and then we could always renew it. Sometimes 5 days. It depends. And some of the recent articles in O are saying give a much higher dose than what we're giving here. So some people are giving higher doses. Instead of 500 milligrams of amoxicillin, they're giving 875 or 1,000, depending on the country. They have different formulations. So it's something that you have to look out for. Keep your eye out. It's changing as we're going along. Keep looking at the literature. We're finding out more. And I put the Z-Pack in at the end. And that's because of my sports dentistry background. Athletes are very notorious for not taking their medications. They just don't know how to be compliant. So what we found out is that if in the training camp we would have these Z-Packs, which it's Zithromax, you only have to take it once a day, and they came in, reported early in the morning, the trainer could make sure that they took their antibiotic and not worry about them the rest of the day, that worked better for them because of the compliance issue. So if there's a compliance issue, it's an erythromycin. It's not as effective as the other 2, but in some patients, you need that. Nobody's really doing culture and sensitivity tests anymore unless it's in a school and they want to do a research study. So we'll forget about that. Corticosteroids and antihistamines, a lot of people thought we should be giving that because these were inflammatory reactions and not necessarily an infection. Years ago, Mahmoud Turabinajad and I and a couple of other people did some blind clinical studies with that, and we found it did no good. You didn't get any difference if you gave steroids or antihistamines. So, maybe there were one or two people that still believe in that, but not really. And analgesics, yeah, a good amount prescribe analgesics, but look at the most recent here. The most recent has dropped tremendously. People are not prescribing analgesics anymore. What they're doing is suggesting that they take over-the-counter analgesics and not prescription. So the most common is ibuprofen. Depending on the country, you have different brand names. I have a few of them up here. 200 to 800 milligrams. If you talk to Ken Hargraves, who's really a big researcher in pain. As a matter of fact, my daughter got her PhD in neuropsychology, and she was doing her thesis on pain, and she came across something called the Hargraves Index, which I had never heard of before, but she asked me if I knew Ken Hargraves because she thought he was a dentist. Well, we're good friends, and he's in the other University of Texas. So I called him up. I said, it's all right if my daughter calls you? Of course. So she called him, and she was thrilled. It was like talking to a rock star that she knew the person with the Hargraves Index. And here I am, an endodontist, and I never heard of it. Have you ever heard of the Hargraves? No? Okay, that's these pain people. So anyway, he says the minimum for ibuprofen is 600 milligrams. Below that, you're not really getting much pain relief. Okay? So 600 milligrams for ibuprofen, and every 4 hours. Acetaminophen in the States is getting a very bad rap right now because of all the liver problems. They're bringing that back on the market, but it's something we need for the people that can't take the NSAIDs. So that's 325 to 1,000 milligrams.
Per dose or per the total today?
No, per dose, okay? And that's, it's a problem because it's not as effective as an anti-inflammatory. So that's why they really sometimes need higher doses. So they sell them in the 500 milligram tablets, at least in the States, so we tell them to take 2 of the 500 milligrams every 4 hours. Naproxen sodium is the one I like the best. Get that in a leave. Or if you want to write a prescription, the patient insists on a prescription, write for Anaprox. I don't know what you have here, but we have Anaprox in the States, which is prescription dose naproxen, and most people don't know about it. If they do know about it, they know too much about drugs, and you have to be careful. So Aleve is what we have in the States, and it's 200 milligram tablets. So the prescription dose is 550. So if you prescribe either 2 or 3 every 6 to 8 hours, depending on the patient, that'll be fine. So the Aleve you use less, and we tend to like that a little bit more.
All these are over the counter.
Yeah, those are all over the counter, except for the Anaprox, because it's a higher dose. And then you have all your narcotics that you could prescribe, but that we're not prescribing that much anymore. So let's summarize this a little bit. For vital teeth, 1 visit if you have time. And if time is critical, do a pulpotomy without medication. Instrument short of the radiographic apex, or to the true apex if you use an apex locator. Adjust the occlusion and suggest an over-the-counter analgesic. That's all you have to do. Okay? That's for vital teeth. Non-vital teeth, if you have time, finish in 1 visit. Same thing. Instrument short of the radiographic apex again, because you're instrumenting to the real apex. Adjust the occlusion again. If there's diffuse swelling, more of the endodontists are still prescribing antibiotics, but we're still thinking about that. You have to think about that one and suggest over-the-counter analgesics. And if all of that, well, let's go to the general trends. I was ahead of myself. General trends we found, more complete instrumentation over these 4 decades, more single visit treatment. Instrumentation is closer to the apex. Fewer teeth are left open, hopefully none soon. Phenolic compounds we're not using. Unfortunately, there's been an increase in calcium hydroxide, but maybe more people will listen to me. I'm not always right, but I tell them I am. And there's an increase in using no medicament. And if all else fails, I found this in a paper, you could always go to prayer. And I want to thank you. That's it for today.